So thank you very much, everybody. We're going to resume the programme now with Richard Edmondson talking to us a little bit about the 100,000 Genome Project and getting towards the end of the session, so we'll hopefully get home maybe a little bit later than the initial planned time. Thank you.
Okay, so thank you. I promise I don't think I'm going to take the half an hour, so I think we'll make up a little bit of time. But I thought in this session, what it might be useful to do was just spend a little bit of time looking at the 100,000 Genome Project, really with a view to asking the question, why did we need this? What was this project about? What it actually was and what it set out to do, and what have we learned so far? There's a huge amount we're going to learn from this project over the next 10 years, and we haven't learned it all yet. I thought it was also useful to try and use it as a bit of an educational session, so I apologise in advance if I take us right back to basics, but I thought that might be quite useful to talk through some of the concepts behind where we're going with genomic medicine. We heard a lot about it this morning, and that's kind of where we are at the moment, but this hopefully will give you some of the background behind that. So if we go right back to the beginning, why do we need genomics in cancer? Then I think we have to say that start that with the fact that cancer is a disease of your DNA. So if we take it back to fundamental principles, cancer is a disease where a cell becomes autonomous by developing so many mistakes in its DNA that it can escape all the normal checkpoints and grow unfettered and unchecked. The best analogy I can come up with is a little bit like your car, where not just the brakes are broken, but the accelerator is locked on full and the steering column is shattered. Sooner or later, that car is bound to crash. If you just have one fault on your car, often you'll get away with it, all right, and it'll be okay. But when you've got multiple faults, that's when the car is going to crash. And the cancer cell is a little bit like that. There is no cancer that I'm aware of that can be caused by a single mutation. In all cases, to develop as a full-blown cancer, you need multiple mutations or multiple mistakes in the DNA to have accumulated. So it's perhaps worth just thinking about what types of mistakes or what types of genetic mistakes we see. And this is going to become important in a minute when we start talking about how we interpret it. So the first type of mistake that we see in the genome is mutations. What we mean by mutations are spelling mistakes in the DNA code. So the DNA code can be represented as this long string of A, C's, G's and T's that eventually code proteins. And mutations are where we usually see just single point spelling mistakes. All right? Now, spelling mistakes are important, but not always, because what happens when you've got a spelling mistake in your DNA is it depends what that bit of the code actually encodes for, what it's making. And ultimately, your DNA encodes for amino acids. And there is some redundancy in the system, so it's perfectly possible to have a mutation, a spelling mistake, that results in exactly the same protein being formed because that doesn't change the order of the amino acids. But equally, it can end up with a problem where the amino acids change dramatically. So as an example, think about the word stationary. Imagine that's our protein. It's made up of letters, so let's think of each of those letters being an amino acid. You can have a mutation called a silent mutation, where there is a spelling mistake underneath it, but the amino acids don't change. So stationary stays as stationary, no change. Equally, you can have mutations that do change the amino acid sequence, but they don't really affect the meaning at the end of the day. So you could imagine swapping the A to an E, but when you hear the word stationary, it's still the same thing. Nothing has really changed, even though there's a mutation there. But of course, you can have mutations that do change it, so the A may get changed to an X. Now we're in a situation where this doesn't really make any sense and that word doesn't work anymore. Or equally, you can have things called like nonsense mutations, which change it and usually truncate it, so make very much shorter proteins. Okay? The reason I'm explaining all of this is it becomes clear that number 1 and 2 there, the silent and the missense conservative mutations, don't matter. So when you study the genome, you find all these things, but actually they don't really matter. It's only the bottom 2 that potentially matter and going to affect the cell and make it work differently. So you see problem number 1 when we're studying the genome is we will find lots of things that don't necessarily mean a great deal. The second challenge we have is there's another type of genetic mistake called chromosomal rearrangements. And these are really common in some cancers. And this is where bits of the chromosomes are the bodies that hold all of this DNA, become fragmented, change around, and reorder themselves. Now that usually doesn't matter at the time that the cell is intact, but when it divides, it means some bits of DNA going into the daughter cells in the wrong order. So suddenly the chromosomes start to look very abnormal, and you can have cells with twice as many chromosomes as normal, sometimes 4 times as many chromosomes chromosomes as normal. And all of the chromosomes are a bit out of kilter, they're a bit out of sync. And we tend to see deletions, where bits of chromosomes are missing, duplications or amplifications, where there are extra bits of chromosomes, and a situation we call loss of heterozygosity, where one strand of the DNA is lost completely and you only have one. This is all really important when you start thinking about the proteins that you're forming. So imagine the situation of amplifications. That cell may be producing many more proteins than it should do because it's got more copies of the gene to do it from. So let's put this into some practice and see what this means. So Elaine showed this sort of graph earlier on, but this is something we call a circus plot, and it's a really good way of representing the genomic changes that can occur in a cancer cell. In a circus plot, the best way of thinking about it is it's a circle. If you start at 12 o'clock, that's chromosome 1, and it goes around 1, 2, 3, 4, right to 23, and the second chromosomes at the end. The way it's annotated, every little annotation around the outside of that is a gene that's mutated in those two cancers. These are two acute lymphoblastic leukemias from different patients. So you can see there's a good, dozen or 20 different mutations in those cancer cells, which fits. I said you need more than one. You've got about 20. The little lines running between show where there's bits of the chromosome that are being rearranged. So one bit's being transferred to another bit. So you can see it's quite a complicated picture. There are lots of mutations and lots of these translocations. And trying to understand what matters and what doesn't matter is really key. That's kind of okay for acute lymphoblastic leukemia. You can read those. If you get close enough, you can actually make some sense of them. You can see, for instance, on the right-hand side, it's a JAK-STAT pattern with mutations in those particular genes. The left has quite a different picture. So you might think, well, we could treat those differently. Now let me show you a high-grade serous ovarian cancer circus plot. Okay, you can begin to see the complexity that we're dealing with in ovarian cancer. Now you've got literally thousands of mutations and probably tens of thousands of chromosomal rearrangements. All of those lines going between the two show where the genome has been changed. The picture is so complicated that how you make any sense of that really sort of defies computational logic. To complicate the picture further, just studying the genome, just reading the ACs, Gs and Ts doesn't tell you the whole picture, because we've hinted at this several times today. There are other mechanisms by which genes can be switched on and switched off, one of which is a process called methylation. Now, we all use methylation in all our cells all the time. It's our mechanism for turning some genes and genes on and off to make our cells different. So a liver cell will have a different pattern of methylation from a muscle cell because it's producing different proteins. But in cancers, you get this state of hypermethylation where lots of genes are being switched off by this process. The problem we have is you can't see hypermethylation using our standard reading technology for the DNA, next generation sequencing. There are other ways of detecting it, but it won't come out from a whole sequence. And then the last problem we have to deal with is the human genome is pretty big, okay? So this is a bit of the human genome written, you can see it's A, C's, G's and T's. It's written at size 4 font, so it's about a third of the normal size of writing. That's not the human genome. In fact, that's not the human genome. In fact, that's not the human genome. That is your human genome. So all of those volumes are one copy of your DNA written at size 4 font, okay? There are 3 billion letters there. It's a pretty big data set to deal with. So you're dealing with huge amounts of data whenever you do a whole genome sequence and read the genome from left to right. And of course, trying to decide what's important and what's not in that is a real challenge. So the 100,000 Genome Project, not to get political, I'm no fan of the Conservative government and their austerity programme. I think they did plenty of damage to the NHS, but this is probably the one thing that they did that was quite good, was they funded the 100,000 Genome Project. And this was so it's a government-funded initiative with the sole aim of introducing genomic medicine into the NHS and making us fit for purpose for the future to integrate genomic medicine and for it to become standard of care. The way they decided they would do this is they would fund 2 cohorts of patients. The first cohort are patients with rare diseases, with the aim of trying to find out causes for those rare diseases that hadn't previously been diagnosed. So 50,000 patients with rare diseases and undiagnosed diseases had their genomes sequenced. The other 50,000 genomes were used up for cancer patients, but in cancer patients' case, they always had 2 genomes done. One is their germline, their blood sample, and the other is the tumour sample, which allows you to then subtract the 2 to begin to see the differences between the germline and the cancer cell. In other words, what's happened to the cancer cell to make it malignant. So they funded 100,000 genomes to be sequenced. The rest, they more or less left up to the community. Do with this what you can. So did it work? Well, it achieved its first aim. It has sequenced over 100,000 genomes. So in fact, it's supposed to be 117,000 genomes are now in the library. That's generated 53 petabytes of data. That's 53,000 terabytes of data, I think. There might be another set of zeros in there. It's quite a big data set. A lot of patients were involved in this. A lot of projects have already come out of it, and I'll explain some of that in a minute. For ovary, we've sequenced 850 patients. So they were recruited from across England. 45, I think, came from St Mary's. Endometrial cancer, it was 760, and 42 of those came from St Mary's. So just a chance to say thank you to the teams at St Mary's who recruited, because it's quite a difficult recruitment process to consent patients and go through the whole process. This is the schematic of kind of how it worked. So if you start with the patient over on the left-hand side, patients donated tumour and blood. Those samples went to the Genomic Medicine Centre up 6th floor of St Mary's. The germline and somatic DNA was extracted. The DNA was then sent over to Genomics England to a central lab, and it was sequenced using what's called the Illumina platform. That's just the particular machine that was used. And the important thing there is it's all sequenced exactly the same way. The really important part of the project then was we didn't just put the sequences away and say, well, that's it, job done. We took on the challenge of trying to feed that information back to the patient. So it came back around the right-hand side to feed back to the patient. Now this is where it becomes really challenging. When you're faced with that amount of data, how do you decide what it means and what you're going to tell the patient about what that means? And this is an area that none of us have had experience of in the past, but we've had to kind of learn on our feet and start to understand what sort of information patients are going to want and how we make sense of it. The way that we did that, and I think most centres did it, was developing a genomics MDT. So that now meets, I think it's still every Thursday, and it's a chance to go through the sequences that have come back, and working with the clinical scientists up in genetics, we can start to understand what the mutations that we're seeing mean. Are they likely to lead to a change in practice of the management of that patient? Do they have familial implications that we need to think about and inform the patient, or are they just quite interesting? And then we can feed that back to the patient. So every patient who's had a genome sequenced has had a feedback from that. The other part of the project then was to develop a research platform. So we developed what are called GSIPs, which stands for the Genomics England Clinical Interpretation Panels. And there's one of those for each tumour site. So we have an endometrial GSIP and an ovarian GSIP, and there's a colorectal and a breast and everything else. And those panels, which are largely self-appointed, but people who are interested, who've come together, they not only provide advice to the genomics MDTs if necessary, but more importantly, direct and drive the research programs that underpin where we go with all of this data. So what I thought I'd do in the last couple of minutes, and as I said, I wasn't planning to take half an hour, is just to tell you a little bit about what I think we've learned from this project. And I'm going to start with some practical things first. The first thing we've learned is that patients, by and large, are actually happy to have genome sequencing. A lot of us thought at the beginning patients would just turn around and say, no, thank you, it's too much, I don't want it, and I don't want all that information. But actually patients do seem to want it, obviously particularly if that might affect their treatment plan. So patients are generally quite happy to have genome sequencing with proper consent. The second thing we learned, which we hinted at this morning, is that the tissue pathways need to be overhauled, because to really deliver whole genome sequencing, you need fresh tissue. Formalin-fixed, paraffin-embedded tissue will just not work. So if we are going to take this on and it becomes our standard of care, we need to really think about how we handle our tissue. Currently, everything we remove in theatre gets sloshed into formalin, then shipped over to the path lab. At a time suitable to the pathologist, they fish it out of the formalin and start processing it, by which time the DNA is so degraded that it's not really going to be fit for purpose. One alternative is we just send stuff to pathology fresh, but quite often we're removing things quite late at night, 7 or 8 o'clock when the path labs are closed, and it can't sit overnight, it'll just degrade too much. So we're thinking about how we might do this, and I think things like vacuum packing materials, so it sends in that case, or possibly even freezing material before it gets sent. But sooner or later, we are going to have to overhaul all of these pathways so that we're dealing with fresh tissue and not formalin-fixed, paraffin-embedded. The third thing we learned was a very salutary tale, that it's actually easier to sequence a genome than it is to collect clinical data. And I think this was a bit of a travesty, really. When we set the project up, everybody was very excited about sequencing, so everybody was very keen to get a bit of tissue, send it to genomics, get it through, get it sequenced, get the result back. What we sort of forgot to do, and I put that in inverted commas because we did think about it, we just didn't know quite how to do it very well, was collect really good clinical data. So we've now got this repository of all of these genomes, but it's really not annotated with very good data about how the patients have survived, what treatments they've had, let alone their baseline characteristics, all of which is going to be really important if we're going to make sense of it. So it feels at the moment that we've got a resource that's not fully complete and fully fit for function. And then we learnt, I think, not the hard way, but we all knew it was going to be a challenge, but we've begun to learn that we all need to learn how to feed back genomic data to patients. Now, when you think about it, we're already very good at feeding back pathological data, and we're good at feeding back radiological data. And genomic data is just going to be another part of that puzzle and another piece of data that we're going to feed back to patients. But understanding the terminology, understanding the implications is going to be crucial, and that's something we're all going to have to take on as a team so that we can pass that information back to patients as we do. And I really see us as the clinicians sitting between the geneticists and the scientists and the patients, acting as that interpreter in exactly the same way we do for radiology and pathology. There are a huge number of events now being developed to try and improve, as a nation, our genomic literacy, but that's something that we clearly need to take on quite seriously. So then, lastly, what have we learnt academically from this resource? So from our perspective, we've got, whatever I said, 850 and 760 genomes sitting in a repository that can be analysed. And I just thought I'd try and show you some of the things that are going on. But this is, I have to say, very much work in progress. I'm not really going to show you a lot of data because most of it hasn't been peer-reviewed and hasn't been published yet. It's in various stages of development, so it really is quite speculative. But I want to talk a little bit about how we just extended our cohort and we correlate with the TCGA, a little bit about new driver mutations, and then some new insights into cancer biology. So I mentioned this morning the TCGA, the Cancer Genome Atlas. That was an American project. It's about 10, 15 years old now. And in that project, they used exome sequencing. So they only read bits of the genome, the important bits of the genome. They didn't read the genome that doesn't code for anything. Whereas the 100,000 Genome Project has coded the lot. So when you're trying to do studies comparing the two, it can be quite challenging because you're trying to sort of compare apples and pears. But we had a master's student this year who, for the first time, has tried to do that. And she took data from the TCGA, data from the 100,000 Genome Project, and then tried to correlate the two. You can see that on the left-hand side, the very left-hand side, that's the flow chart she used for TCGA. It's very simple. It's a straightforward process to extract data. I could teach anybody in this room to get data out of TCGA in about 10, 15 minutes. It's got a single web portal. You can go on, you can type the genes of interest, and out comes the result. The 100,000 Genome Project, the data is in a much more raw format. It takes a lot of work to actually get the data out and make any sense of it, and it's protected, quite rightly, behind a lot of firewalls. So it's actually quite difficult to work with. And you can see the flow chart there for the 100,000 Genome Project was much more complex. But nevertheless, she got data out, and just to explain what she showed, the plot at the top shows all the ovarian cancers that she looked at, and she's divided it on the left-hand side and the right-hand side by whether they've got genes related to HRD, homologous recombination. We keep coming back to that phenomenon today. So the HRD are on the left, HR competent on the right, and then underneath, the bottom half of the box shows all the genes involved in the immune pathways. And when she analysed that, what she showed quite clearly is the BRCA-related cancers have a greater immune positivity than do the HRC tumours, suggesting that there may be more scope for using immunotherapy in that particular cohort than the other. So using this data, you can begin to bring out sub-cohorts that may be suitable for future treatments. Sorry, I've gone the wrong way. So what about new driver mutations? So endometrial cancer has already been analysed. There's been a lot of work now done to analyse the endometrial cohort. It is being prepared for publication. It's an incredibly slow process, but hopefully we're getting to the first paper coming out. I can't show you the massive data underneath it, but I will just tell you that it's confirmed, no great surprises, there are 4 molecular subtypes of endometrial cancer. So everything I told you this morning is still true in the UK cohort. We have that copy number high, copy number low, that's P53, NSMP, MMR, and POLE groups there. There's a lot of work reanalyzing that, but I think some of it is beginning to show we've got new driver mutations, new key mutations that we're identifying that are responsible for driving the cancer, particularly in that NSMP group. So I hinted this morning there may be ways of splitting that group even further, and this is the sort of work that's going to take that on. So kind of watch this space, but I think there's going to be quite a lot coming out from there. And then, sorry, I keep doing that. Lastly, we are getting some new insights into disease. So ovarian cancer, the data set has been very crudely analysed so far. No surprises, it shows there's a 50% HRD rate, which is exactly what we'd have expected from everything else we knew, so that's good. But by the fact we've got the whole genome to look at this time, we can look at that in slightly more complex ways. And a group led by somebody called David Wedge at the University of Manchester is beginning to look at processes called chromothripsis, which is how a lot of these chromosomal rearrangements actually occur. And it's giving us some really important insights about how the pre-cancer cells that we know exist in the fallopian tube change into the cancer cells that cause all the damage. So I think we are going to get some really important and new insights into cancer biology from this data set. So I'm going to finish there by saying genomic data is already providing important stratifications for our patients. We are already using this sort of data. We went through that this morning. But from now, we're only going to see that increase. So as a community, it's imperative now that we improve our genetic literacy and sort of start to talk in these terms, because this is kind of the future direction. I hope that was useful. Very happy to take any questions. Excellent. Off the hook.
Off the hook. Hope you get published soon so you can come back and share.
Yeah, I know.
Good luck. Thank you. I'd now like to welcome Alison Armstrong, who's going to give us a gallery update. And I'll let her explain that to you. Most of you will know Alison as the Associate Director of GM Cancer Alliance.
Thank you very much. Oh, I'm not going to talk about that. I wouldn't be very good at all. There we go. This is much more comfortable for me as a subject matter. So Alison Armstrong, the Associate Director of the Cancer Alliance. Just before I talk about NHS Gallery, it gives me a good opportunity to thank Eden and Nadia and the Academy team on behalf of the Alliance for putting today together. And I'm sure Nadia will thank each and every one of you for sparing your time. I know you have busy jobs, so taking a day out is a real push for you, but thank you. So I'm just going to talk to you about NHS Gallery. Forgive me if you already know the background, but I'm just going to go over it again. So the background to NHS Gallery, our Greater Manchester findings from the first year, which who knew are called year zero. The current position, which is where we're at now in year one, or the second year of the trial, and then what is next for NHS Gallery. So a little bit of the background. So NHS Gallery was put together, so it's a collaboration between Cancer Research UK, the King's College London Cancer Prevention Trials Unit, in association with the NHS and Grail, who are a US healthcare company, because NHS Gallery is commonplace in the US. So it's a randomised trial, it's a prospective trial. And the aim of it is to establish if this screening programme can be used alongside the existing screening programmes that we've talked lots about today. So we were fortunate in GM because we were chosen as one of 8 cancer alliances, there are 21, you probably know that, to take part in this trial. And Nadia said on her first slide this morning, this is around supporting the NHS long-term plan in terms of increasing the stage 1 and 2 cancer diagnosis to 75% by 2028, and we're some way off that. Got to press hard. I'm now slightly embarrassed by this picture after Richard's very technical display. But he did talk about methylation patterns, which is how NHS Gallery, which is the name of the blood test, works. So it picks up the pattern from the DNA, and that's associated with a cancer signal being detected. That links then to a cancer signal origin, or a CSO. There are 21 possible cancer signal origins, and they cover over 50 different cancer types. So here are the 21 cancer signal origins. So you can see from a gynae perspective, there are 3. cervix, uterus and ovary, which includes the fallopian tube element. So just to give you a little bit more information about the study design. So the study aimed to recruit 140,000 participants in the trial. Blood was drawn, so 2 10ml vials of blood was drawn using a mobile van, a little bit like the targeted lung health checks van. So it's quite a large operation. And then those participants then were randomised into either the interventional arm or into the control group. If you go into the control group, your blood doesn't get analysed, it just gets stored. The participant doesn't know which arm of the trial that they get entered into. If you're entered into the interventional arm, that plasma then gets shipped to the US for analysis, and then that will either come back following the test, the Gallery test, as no cancer signal or a cancer signal detected. And the test can either detect a single cancer signal origin or 2 cancer signal origins. If the patient's blood then picks up a cancer signal, they're referred into secondary care on a 2-week wait pathway. So not everybody had the opportunity in GM to take part in the trial. You had to fulfil criteria of being in the age bracket of 50 to 77. You needed to be registered with a GP in GM, but also having not been diagnosed with cancer in the last 3 years or under treatment or follow-up. I've already said that the aim was to recruit 140,000 across England, so each Cancer Alliance was tasked with recruiting 20,000 participants, and I must acknowledge the work of the localities in terms of supporting us to publicise the trial. We really wanted a mixed bag of participants. That was really important as part of the trial. This is the latest information, unfortunately, which is at March 22. You can see from the numbers here that there's a real mix of male, female. We've talked quite a lot today about deprivation. There was a mix around deprivation centiles. A mix of age range. Remember, we had a small age bracket anyway. But the thing that wasn't great was around ethnicity. So there was a real push on the back of this provisional data, and this wasn't just GM data, this was national. So a whole host of more diverse participants were recruited. So if the participant did have a cancer signal origin detected, what happened? So I've explained that the patient came in on a 2-week wait pathway. NHS Gallery produced some information about what diagnostic tests that the patient should have in line with the 2-week wait diagnostic tests. They have a separate referral form that gives you the real basics, the demographics of the patient, the participant and the CSO, and that's it. You don't know whether they're a smoker, you don't know what the medical history is, anything like that. You do get the bare bones. The participants informed by telephone with the King's College London clinical trials team nurses and explained that they'd get a referral into secondary care. At that point, the GP is notified, but there isn't an action for primary care at all. So I've explained as well that each one of the 21 CSOs is linked to a 2-week wait pathway, and also I've explained around the 2 CSOs versus 1 CSO. So this is what the van looks like. So because of the size of it, most of the locations were like Tesco car park, IKEA car park, although we did have a small van that then did come to do a mop-up because there was some, we talked about the inequalities element that made it more accessible for some groups of participants. It was normally parked in that area for between 2 and 4 weeks, dependent on the numbers. So what did we find? So there is very, very little information being shared by the national team. So really thankful to all the provider teams for giving us the information. So firstly, in GM, all 10 localities were involved in the trial. We achieved our recruitment. We got 20,049 participants recruited. And out of that, bearing in mind only half of those will have had the blood analysed, we had 101 referrals into secondary care, which equates to 1% of participants. What we were quite surprised about, because of course this is a trial, is the number of participants that were referred in with a second CSO. So that was 65%. I think they've now nationally looked at it and it's 3/5, so we're a little bit higher than that. The 1% of participants does match what they've said nationally they've found. So we've got around 49 cases that have shown after investigation, so 50% of patients that were referred in with a cancer signal origin after they had their diagnostics shown to have a cancer. If you think about the comparison with those numbers versus a conversion rate for maybe a 2-week wait, that's massive and is an exciting opportunity. In terms of how accurate the test is, there was an 84% match between the first cancer signal origin and the confirmed diagnostic outcome. So there was a match in that location. 12% matched the second CSO, and there were just 2 patients that neither matched the first or the second, but a cancer found in an alternative location as part of their workup. So here's just a breakdown of the disease groups. So that 4% is the gynae, 2 patients. Incidentally, the top 6 accounted for 65% of the cancers detected. So we had 11 CSOs referred, directed to us out of the 21. So how do those top 6 CSOs match GM to national? You can see they're all but identical. This is in alphabetical order, but colorectal was the top of the tree in GM in terms of the more cancers detected. When we originally presented this data, we didn't have this staging information on these patients, but we have it now apart from, we've just got a small number of staging data bits left remaining. They're all haematological cancers, and I understand that the staging of those is slightly more tricky. And also, they're not that well documented at MDT, it seems, because that's how we've got this information. So you can see the breakdown of what came in at stage 1, 2, 3, and 4. Obviously, the next year we would hope that we're catching more early cancers because we've only had a 12-month gap between where we're at now. So that was 42 patients that we've got the staging data for. And that's the information specific to gynae. So 7 referrals in total, and it was the 2 patients with ovarian CSO that were actually the 2 positives, 1 being stage 3 and 1 being at stage 4. So this is the current position, so October 22 to July 23. So the focus for this year is actually retaining the participants from the previous year. So there isn't an opportunity for individuals to join the trial now because it's over a 3-year period. So the actual year 1, the second year of the trial ends next month, July 13th, and then we'll have visited all the 10 localities again, getting patients to come back. The average retention rate, the aim of NHS Gallery was to have 92% or more patients retained. We're not far away from that, and this is the experience from other 7 cancer alliances as well that were involved. Very top the tree with 93% participation, not that it's competition. And to date, just to give you a flavour, we've had 54 referrals in, so just slightly more than half of what we had last year. So that we would hope that they're the patients that have developed a cancer in the last 12 months, and we would hope for that reason that we're catching them at an earlier stage. Providers are now collecting the data as they're going along about the stage of disease, so we can present that again. Comms has been really, really important to try and promote the trial originally, but also retain participants. A lot of that has been done, granted, with social media, but it's worked incredibly well. And we've been able to target certain areas or groups or localities. So what next? So I've just explained that we're on the second year of the trial. The third and final year will be October 23 to July 24, but the results, the formalised evaluation, will be issued in April 24. There's an expectation that this will continue as a pilot study. There has been some work on the NHS IIP, which I don't know whether any of you managed to attend NHS Confed Expo last week, but some details were shared at that. And that pilot will offer up to 1 million tests in England. So all the cancer alliances that weren't involved previously will have their population able to participate in what will be a pilot. And this is the comms that's been issued just in the last week since that information was shared at NHS Expo. I think, if I'm honest, some of it's a little bit over-egged, but I think, we're wanting to grasp onto anything in terms of positivity, but certainly our findings in GM were incredibly positive. That's short and sweet. Recruited some time.
Very much, Alison. So that was a great overview, and just to clarify, the Gynaecology trial is about asymptomatic populations being screened to try and pick up earlier cancers. And I think it's really exciting. We've got a few of these projects ongoing, haven't we, to try and get to the point where we're diagnosing cancers before they're causing any obvious symptoms. Hasn't really worked out for ovary, though. On our 2, they're still coming in at stage 3 and 4 on the 2, the small numbers. But we'll wait and see. Any questions for Alison before we free her? Jen?
Hello. Hi. That was really interesting. Thank you so much. And exciting. My question is, other than a smaller van to access more ethnically diverse communities to recruit, anything else that was done that was, I guess, successful?
Yeah, I mean, we did. There's a lot of learning from this from very early on. So we were the second Cancer Alliance to go live. So there was translation services available. There was information produced in various different languages. We could dictate in GM which languages we want when we pushed hard, but that took some doing. GPs we could involve if we so wished around encouraging members of their practice to be involved, but I think there's been an acceptance that there wasn't enough done.
So what would you do?
If I had my time again? Well, we've talked quite a lot, haven't we, about, I said there a lot of social media was used. That doesn't necessarily get to lots of different communities, and I think that's going to be something that they're going to work on in the next round, is how do you access, Manisha talked about using community leaders to promote, and I think it's those elements that it's no different for this really than the screening or any other element, is how do we capture those. It's not hard to reach, is it, anymore, it's a different term. Communities, and how do we promote these opportunities. So I think it's a really difficult one, but I think the same rules apply to it all, Jen.
That was really interesting. Can I just quickly ask about endpoints? Do you know what the primary endpoint of the trial is? And the reason I ask is we got ourselves not stung, but when we did the UKC tox trial, which is the big ovarian cancer screening trial, that was powered on mortality. And although it did pick up more cancers when we screened, it didn't make any difference to overall mortality. Is that what's happening here, or is it just about cancer diagnosis?
It's merely cancer diagnosis.
So we could run into exactly the same problem where we're very good at picking up cancers, but it makes absolutely no difference. Yeah. And that's what UKC tox showed.
Yeah. I think you're absolutely right. I don't know whether that's been clocked, to be fair.
Yeah.
But I think, obviously, as the years go on with this trial, you are going to be getting, you would hope, be getting more patients that are early stage, so it will be making a difference. But you're absolutely right. That's not been, it's not part of the trial.
Yeah. So on that one, with an ovary, I think a lot of us have come to the realisation that there probably isn't a natural stage progression. It may not be that stage 1 turns into 2, turns into 3, turns into 4. Some cancer is always 3 and 4, some cancer is 1 and 2. And so I think we may see some stage shift where you're seeing them slightly earlier in each stage, but not crossing the stage boundaries. But it's a shame because it's not really going to come out of this, I don't think.
No, and we had some of that of patients this year that have had the same cancer signal that was investigated last year, but on investigation they didn't find a cancer, and then they come in again with the same cancer signal origin, and then there's got to be a risk-benefit about, do we reinvestigate those patients?
I mean, that's analogous to the Ray CO125. We've got loads of patients who've got consistently Ray CO125. It doesn't change over decades, and this will be exactly the same.
But I think that's what I was saying about the risk-benefit, is it needs some discussion with the patient, say, yes, you've had this cancer signal origin again, same as last time we'd investigate it. Even if it is a cancer, it wouldn't change your outcome anyway, so there's very little point.
Yeah.
Talking on that, what's the provision for anxiety for the patients, especially those that have these signals but nothing comes of it?
Yeah, so the counselling's available via Macmillan, so the patient's directed to there. I mean, to be fair, the King's College London nurses have been brilliant, but that was the infrastructure that's in place. And all the patients came in via an RDC, so they all came in the same front door, and the RDC teams have done a little bit of that informal counselling with the patient. So, but it's a really good question.
I think what's being fed back through Pathway Board is a plea to think about who sees these ladies, and certainly stratify it to the MDT clinicians, and to be aware that there is going to be anxiety, and if we don't find a cancer, as in 50%, you're going to reassure them they'll be re-screened in a year and checked again at that point. And I think it's been left to clinicians to decide whether they re-image them, whether they repeat MRCT, depends on the cancer screen origin. And I think that's quite individual, but they are small numbers, and it's been recognised that this will induce anxiety. We don't have an answer, just be mindful and maybe appreciate it. But again, it's a bit like, it's piloting screening for the population. This is what we're doing. We don't know if this is going to be a Pandora's box or not yet. Any other questions, comments? Nope. I did kind of want to be recruited, but I wasn't. But now I know the criteria, I'm happy. Thank you. Right, I think it's me actually. What I stood here for. Right, so I am going to talk about another pilot population screening research project, and this will be the last presentation of the day. We'll round off with a short user's video just before we abandon and go into town for a drink, people. Okay. So I'm going to talk a little bit about a population genetic testing study aimed at the Jewish population, and it's come to be known as genetic study. This is an NHS England commissioned study with some engagement with some Jewish charities that I'll come to in a moment. Don't be embarrassed about your slides. That's my explanation of BRCA. Okay, so very straightforward. BRCA1, BRCA2 people, meet them. So BRCA1 and 2 are tumour suppressor genes that we all have, but where they're associated with mutations can increase the risk of a variety of cancers, such as breast, ovary, prostate and pancreatic cancers. Around 1 in 250 people in the population carry this mutation, but what is well recognised that it is much more common amongst Jewish populations, particularly with multiple Jewish ancestry, so multiple grandparents with Jewish origin. So with specific reference to the Jewish population, 1 in 40 Ashkenazi Jews will carry a BRCA mutation. And Ashkenazi Jews are Jews of Eastern European origin. And when this statistic particularly refers to Ashkenazi Jews with 4 Ashkenazi grandparents. So the whole history is of that group of Jewish ancestry. The incidence of BRCA mutation is lower in the Sephardi Jewish population, 1 in 140 carrier of BRCA mutation. Again, higher than the general population, but lower than the Ashkenazi Jews. And for those who aren't familiar what Sephardi Jews are, I had to look it up. It's the Jewish population of Middle Eastern and Spanish origin. Okay. Okay, and a great way of Google is say the Ashkenazi Jews, you can check their diet. It's a lot of dumplings and matzo balls, cold areas. The Middle Sephardi Jews, much warmer Mediterranean diet and spices. So that's a good way to remember. So, as I mentioned, a 1 in 40 risk of BRCA mutation in the Ashkenazi population, which equates to a 2.5% incidence. If we flip that on its head, if you look at the ovarian cancer sufferers amongst the Jewish population, 40% will have the BRCA mutation. And of the breast cancer sufferers amongst the Jewish population, 10% will have the BRCA mutation. And if you look at the risks with BRCA1 and 2, as shown on this slide, I've underlined the ovarian risk. With BRCA1, the incidence is around 44% of ovarian cancers. And again, with BRCA2, 17% are associated with ovarian cancers. So both BRCA mutations involved, but BRCA1 more strongly. Okay, so this study was by, I've forgotten his name now, sorry, Professor, that's him. Yeah, that's him from UCL. He developed this population screening project to look at BRCA1 screening amongst the Jewish population in North London. And what he found that the incidence of BRCA mutation was around, was in line with 1 in 40 of the Ashkenazi Jews, but 50% of the people with mutations wouldn't have been eligible for screening based on family history alone. So this is a part of the population you can't identify by our routine family history screening route. And only 11% of the BRCA positive Jewish community were aware that they were. So without knowing, you can't be aware that you may require enhanced screening and different risk-reducing treatments. So NHS England launched this genetic study and work in collaboration with Genetics and Chai Cancer Care charities. Genetics is a Jewish charity involved of screening for genetic abnormalities. I think it initially was set up with aimed at newly married couples that were looking to have a family and wanted to be aware of their increased risk of genetic abnormalities and be informed of what their risks were and the counselling around that. And the Chai Cancer Care charity is around supporting the Jewish population through a diagnosis of cancer and living with cancer. The aim of this study was that to try and identify BRCA carriers in the Jewish population over a 3-year period. And this would mean they would then be able to access the NHS standards of surveillance and risk-reducing treatments. So this very much ties in with the NHS long-term plan. Can we get to people before their advanced cancers, early stage 1 and 2, much like the theory of Galleri trial, but we need to watch this space. And it is of note that this is already established population screening in Israel. So it's been rolled out already as population screening. So to be eligible for this study, the NHS has worked closely with Genetics charity to engage the Jewish population. There's been a huge amount of fundraising and comms to the Jewish populations through events and social media to engage the Jewish population to enroll. Eligible people would be anybody with 1 Jewish grandparent. Doesn't matter whether it's Ashkenazi or Sephardi. So we're not expecting as higher incidence as 1 in 40, but this is throwing the net wide. Anyone who's at least 18 years of age and lives in England. Okay. The people need to enrol themselves on the study, so they need to be engaged, but they need to themselves enrol on the study. And Genetics and Chai charities, Chai Cancer Support, provide support and engagement, recruitment, support and counselling throughout the process. The box on the right shows the numbers of Jewish people in the populations in the different areas across England. And as you can see, the Northwest comes in 3rd. London has the highest percentage and numbers of Jewish population, followed by the East of England, and then we come in 3rd place. And the bulk of our Jewish population will be found around North Manchester often, and there's pockets around Cheadle and some areas in Stockport. So on the 2021 consensus data, we would expect 309 BRCA positive people from the Jewish community for the Northwest region. This is the flowchart that underpins the study. So firstly, there will be engagement through the genetics charity service, and people will be invited to enrol in the study through the online access. Once they enrol, they will be sent the test kit for a swab to take a salivary sample. The genetics charity organises all of that. They post out the genetics testing kit to the person at home. The person takes the sample and it's returned by post, and it's processed in the Royal Marsden in London or Manchester Foundation Trust here. The test result then returns to the direct team of the genetics charity group that have had some additional training for basic genetic counselling. And they would then be responsible for contacting the person, informing them of the results and next steps. They'll ensure the patient has the information sent to them in written form and verbally over the phone. They will then refer that person, not patient yet, person, to the formal genetics clinical labs where they will arrange to see them remotely and arrange specific genetic testing. There will also be comms to the GP at that point, informing them of this. The genetic counselling hotline is available to women and men who screen positive for BRCA throughout this process. And we need to note that it's taken an average of 9 months from referral to the genetics lab to having a referral. Another route for 2-week-wait referrals for gynae. Look out for this. Okay. So stressful, but the genetics are meant to be providing support around this time. So this is just really covering what the role of the genetic counsellor is, as I've spoken to you already. They also, once the person has BRCA positive result, will refer that person into the NHS screening programmes. So breast screening for breast, related to breast, and following the national guidelines, certainly for ovarian. So if there's risk-reducing treatments to be considered, they will notify the study subject that this will happen if they're confirmed BRCA positive. And very importantly, as we've flagged with other things, cascading the information, because it's not only going to cause anxiety to the study participant, but concerns potentially about their relatives. And they need to then throw the net wider and invite relatives to come in for screening. Okay. So it's going to propagate this. The clinical genetics service will do the more detailed counselling and discussions about what the NHS screening involves, what risk reducing is involved, lifestyle measures and screening for family members. So far, what have we got to? There was a soft launch by the NHS in January 2023. Initially, the plan was to roll out 200 tests per month across the UK. Interest was huge. Genetics and Chi Cancer did a great job. 1,000 people enrolled in the first month. So it was quickly increased to 400 tests per month from January. And that's across England. The intention is we bed that in and roll out the hard launch from October, where we're expecting to have 540 tests per month across the country. The initial modelling of a pickup of 2.5% incidence of BRCA abnormality is based on having 4 Ashkenazi grandparents. It's probably going to be more around the 1% mark. And this should really be viewed as a feasibility study. It's a pilot study to assess feasibility of BRCA testing of the population. So what does this mean for GM? More work. Across GM, not that much, we think. During the soft launch, we're expecting 1 BRCA positive person per month across the whole of GM, very likely to be in North Manchester. Okay, so 1 person. During the hard launch, where we're running 550 tests per month across the country, we're going to expect to have 1 to 2 every month positive. Genetics charity is meant to be the first line of support, but I have mentioned the waiting time for formal genetic counselling and screening and testing. So we expect some anxiety from patients and GPs, and we may end up seeing some of these patients through the 2-week wait referral through anxiety. If they do have formal genetic testing and confirm they're BRCA positive, then they will need to be referred into the NHS programmes of risk-reducing surgery, hysterectomy, BSO for ovary, breast screening, prostates. I imagine they'll go for PSAs. So they need to look at what they would do for these groups. The study itself funds the testing and the testing alone. So there's no money going to follow these people through if they're referred into the system for actual risk-reducing treatments or ongoing screening through the breast programme, for example. However, the hope is that these will equate to savings if we're picking them up earlier, but we don't know what the outcomes are going to be yet. There have been some specific ethical concerns raised because actually young women who are BRCA positive are not referred under 40 for the routine breast screening programme as it is, and they have a 2 to 3% risk of BRCA abnormality. Young women with family history of breast cancer have a 2 to 3% risk of having BRCA mutation, but they're not going through the screening programme. So the feedback really from NHS England is, yes, I can see there could cause concern here, but this is a pilot feasibility study. It's just the start of seeing, is this something we can roll out? That might create some questions there. So in summary, yeah, exciting feasibility study. That's the main thing. Can we do this and is it worthwhile? We're not expecting high numbers in GM. There were really good comms amongst the Jewish population, but there was really poor comms with NHS England to the cancer alliances. And actually, we only were made aware of the soft launch in April. Isn't that good? Started in Jan, and we knew in April. So we have been trying to catch up on this space. And just yesterday, I had an email round of a flyer that's going to be released informing everybody of the genetics project. We hope to have some today, but we couldn't get them printed off in time, so we'll circulate it by email or go on the GMC Cancer Alliance website. Okay, just 1 second. That's the end of my genetics talk. It was just a really quick update and introduction to everybody because the comms was lagging to get us all aware of it, and I'm sure we'll be starting to see 1 or 2 of these ladies come through in some areas across the next year or so. Thank you. Any questions, comments, any concerns? I've had some discussions with Claire Garnsey already around this because there were obvious breast concerns around this study, but it is here. It's arrived. Okay, so thank you. What I thought would be nice is just to round off with a final user video or patient story. It's a very short one, but I think it's quite helpful to round off the day.
My name is Kathy Morse. I'm 55 and I was diagnosed in 2020 with very rare stage 3 vaginal cancer, and I'm a mum to 2 daughters in their 20s. My treatment involved 7-hour complex surgery, tumour removal, skin graft to reconstruct me internally, lymph node removal, and the cancer had spread into my lymph nodes in my groin. And 5 weeks after surgery, I had 5 weeks treatment, chemoradiation, which involved 25 rounds of radiotherapy, 5 full rounds of chemo, which gave me horrendous radiotherapy burn. I was quite lucky on the chemo. I know it's not everyone's experience. I felt sickly, but I wasn't sick. I didn't lose my hair and I managed to eat as normal, which was quite pleasing, seeing as I was suffering with radiotherapy burn and the after effects of the very complex surgery. I definitely like to see more awareness and just try and break down this taboo of people talking about the gynecological things, and hopefully manufacturers to put more awareness on products that are aimed at women. I think it'd be quite an easy thing to do that.